All right,
Okay.
I see you.
Yeah. What I had to do,
Perfect.
I had to go to Teams and allow you to get my camera. That's what
Ah,
happened.
okay.
Okay.
Perfect,
I'm here.
perfect.
Okay.
Yes. So happy we can see you and thank you so much. I will
No problem.
formally be starting the webinar now. And just
Okay.
thank you so much for everybody's attendance. Thank you for everybody's patience and just wow. I mean, in these past couple of webinars, guys, we've been having a variety of individuals. As you know, if you've been checking in, we've been having individuals who are influencers. We've been having medical directors. We've been having residents, everybody sharing their invaluable information and insight for our upcoming match cycles. Today's webinar is going to be like no other. Today, we have the pleasure of having Dr. Cedric Coleman. Thank you so much for joining us, Dr. Coleman. Dr. Coleman is a graduate from the University of Illinois School of Medicine. He graduated in class of 1982. And since his residency in 1986, Dr. Coleman has been teaching future generations of students, which I think is so amazing. He is an assistant professor of internal medicine at Rush University Medical Center, and he continues to mentor individuals. He has expertise in treating diabetes, hypertension, bronchitis, among other conditions, but his unique approach to teaching is something that I would like to point out because Dr. Coleman he has a very good way of blending the virtual world with the traditional world of internal medicine in the form of telerotations. So, thank you so much once again. A warm welcome to Dr. Coleman, and thank you so much for joining us once again, Dr. Coleman.
No problem. No problem. What would you guys like me to start in talking to your people?
Sure, sure. So, I mean, I think what's most remarkable to me is just how long you've been teaching so many generations of students. I think it's kind of a loaded topic, because firstly, I think the biggest question that stems from them all is what inspired you? What is one of your biggest inspirations between being an educator, teaching students, teaching medical students, and all the like?
Good question. Well, when I started at um, Rush had never had a non-white chief resident in any department ever at all. So going through intern of the year, resident of the year, then I eventually became chief resident. I wanted to keep that academics going. So regardless of what I did clinically, I still wanted to be on top academically. So the best way was to do that was to do teaching rounds at the hospital and then my practice. Well, after a little while, one is going to suffer because if your practice is good, then you need to be in the office. If the teaching rounds are good, then you need to be doing teaching rounds. So then we incorporated that into our office. And then what we found out, for a little while, I stopped seeing patients in my office, students in my office. We just started doing the telerotations because I sat and I talked with the program directors and they said, hey, these guys are telling us that they're rotating at these places, they're doing these hands-on things. And I'm just going to tell you what they told me. They said they get to us and they don't know shit. And at first, I thought the program directors were just really kind of exaggerating. So when I started seeing students back in my office again, I'm going through the stuff I'm expecting them to know, and they were right. They would have done 8 weeks of internal medicine, but then when I'm going through the stuff that we normally do, they couldn't answer the questions. So I said, okay, I don't know if they have you on their, I don't know what they're doing. If on your rotation they got you doing their work, writing their notes, um, you know, bringing their coffee, whatever they're doing, but they're not teaching you what the program directors are expecting, and that's the deductive thinking. Okay, so we have a two-tier program. We have one where we do still see people to come into the office, but then two on our telerotation, which by the way is the only one that's mentioned on the AMA website, that's our major focus because that's where we get most of the academics done. That's where we could come in and we have people in our office who can't participate with the telerotation because they're two separate things. And in the office, yeah, we're focusing on the clinical stuff and things like that. But in the telerotation, we're focusing more on the academics because the program directors said they get to us and the deductive thinking isn't there. They heard something
Mm,
about diabetes, but they can't put the story together. Because
mm,
in the United States, with all the knowledge and everything that we should have the cheapest medical care system in the world. The reason it's not is because it's a hospital-based system. A lot of our patients are in the hospital. And at $10,000 a day, average admission is 4.5 days. That's $44,000. A person is admitted to the hospital 3 times, they could have paid their mortgage. So our inability to take care of patients as outpatients has been a big factor. So we've developed these chronic disease centers to look at what are the major admissions. 80% of our admissions in the United States are hypertension, congestive heart failure, coronary artery disease, COPD, asthma, and I may have missed something else in there. But those are the major things. We should not have patients in the hospital because we cannot control their high blood pressure, or we cannot control their diabetes, or if they do have a history of heart failure, we can't keep them from getting so short of breath that we can't manage them. But everything is focused on in the hospital. I get a person, we get a patient, they fall out there in septic shock. The student knows what to do, or the patient is in DKA, they know what to do. But if a person has a blood sugar of 800, and then they're looking at them, well, we need to send you to the emergency room. This person said, no, I'm feeling great. I don't have to go. And they're right. The thing is, they're right. We
Yeah.
have data that show that we can manage that. They don't have to go to the
Mm.
emergency room, but they don't know what to do with that. And that's the
Mm.
whole big. So we have the telerotation to put in all the academic stuff that they may not have had a chance to go through in their regular rotations. And believe it or not, we average about 200 students, 200 of our people match every year. And out of those 200
Mm.
people that match, if 20% ever set foot in my office, I'll be surprised. Yeah, we have a match rate higher than most programs, most medical
Mhm.
schools, you know,
Wow.
if I may say
Mhm.
so. And the great majority of our people become chief residents if they want to.
Wow.
We make sure that
Mhm.
they're 3 years ahead of all the other interns because we're doing the literature that's right now. We're going through the data now. And if we waited for that
Mhm.
data to come out of the textbook, we're 3 years behind. The textbook is already
Mhm.
3 years before you get it. So it's a
Mhm.
combination of clinical in the office, but then to add to that for the people, because a lot of people would have had a bunch of rotations. But then when we go through our information on the telerotation, that's where the academic stuff comes in. And that's where I
Mhm.
see where the program directors are complaining with the deductive thinking, putting everything together. Because, they'll do a cardiology rotation, they'll look at echocardiograms, they'll look at the mugger scans. But like I tell them, that won't help you at 2 in the morning when your patient is short of breath and can't breathe. We need to know
Right.
the practice stuff. And we focus more on that. And we've been very successful. We've been successful in our practice, taking care of our patients, and we've been successful with our students that match.
Wow. No,
So,
that's so amazing.
and this whole big thing about the telerotations don't help. Like I said, we're the number one telerotation program, and most of our people that match never set foot in our office. So that
Wow.
myth, they need to get rid of that myth that
Mhm.
you don't, you just have to be in the office to be there because the program directors feel that you're not getting everything that you need there anyway. So if you can get a
Mhm.
combination of both, that would be helpful, but you do not hurt yourself by not doing the
Hmm.
telerotation. And I do both. So if somebody said I'm going to come to your office, I'm there every day. So it's not like I'm
Mhm.
pushing one over the other one because that's all I do is that I get to see both sides.
Wow, no, that's amazing. And
Yeah.
so I like how you mentioned the integration of the in-person rotation versus the deductive reasoning and integrating that into the virtual rotations. Um, Essentially, is one better designated for another? If maybe if it's preferential, could one elect to do in person versus the telerotation? How really do they differ?
You know what? Because with the tele with the inpatient rotation, like if you go anywhere else, if we're getting ready to do some academic stuff. If a patient comes in with chest pain or a patient comes in their blood sugar is 800, teaching is over. Okay, the patient gets
Mhm.
priority there, and some things, and there's no way for me to cover the amount of material in our regular rotation than we do in the telerotation. In the telerotation,
Mhm.
we control everything. It's a patient presentation. Now, these are real patients. These aren't
Yes.
made up stories and stuff. These are real patients. And one case that we discussed
Mhm.
it takes three 2-hour sessions to go through, and it covers
Mhm.
250 different topics. And the program directors got to review that, and they wanted to make sure I had to promise them that my students would go through that, if not
Hmm.
anything else. And then cover the other topics, because we cover everything that we told you about that people get admitted for. Those are the main things
Hmm.
that we want to make sure that our
Hmm.
patients take care of themselves as interns at 2 in the morning when no one else is
Hmm.
around. Yeah. And
Wow, wow,
the big thing is that everything is literature based. So not
wow.
only are they doing
Mhm.
clinicals, we're preparing them for boards also.
Wow, wow. So it's a very integrative program. You get
Yeah.
both the clinical experience, you get the board prep, you really try to, get the biggest benefit for the student during that
Yeah.
rotation. And another question I had is really just kind of what the structure is and just really the end result. How can students benefit the most, or how can one get the most benefit from a virtual rotation?
Okay. Well, to compare the two, with the clinical rotation, it's the clinical rotation. We have the patients that we have coming in. We see the patients, but then we try to do the academic part with each individual patient. Okay. Sometimes that's hard. But then at the end of the day, we save some time to try to do some of the stuff that we do in the telerotation. It's not possible to do that. No way to keep
Mm,
up. But at
mm,
least for those we get all the academics to go with that. Okay. With the telerotation, is structure to make sure
mm,
that we do COPD and asthma, CHF and
mhm,
congestive heart failure and coronary disease. It's made sure that we go through hypertension and diabetes, because of the fact that we have chronic. I mean, we're so poor at managing those as an outpatient. We have chronic disease
mm,
centers just for those illness, because we can't take care of them. And the thing is, the chronic disease center should be in your office. I mean, you should be able to manage those. Matter of fact, we just got recognized by the powers that be that we were number one in the country in managing those illnesses. So that was pretty good. That was pretty good for me to get
mhm.
that, and then bring me in the extra money. Right. but
Right,
but at
but
least
at the end of the
they're
day,
right,
it's all about the impact, right?
right, right. But at least other people get the data and they can see
Yeah.
how we compare with everyone else. And like I said, when I talk to the residents, I said when you go out and you do well, you bode well for the program. And most of our people do very well. So a lot of times when I
Mhm.
call the program directors, because everybody that rotates with me get one phone call. Okay.
Wow.
So I tell them, I said, you have to make sure where you want it to go. Because if it's your number three choice, when I'm calling them, I'm not calling them as your number three choice. I'm calling them because we want you to match right now.
Mm.
Um,
That's right.
that right. So the program directors got a chance to look at that. They look at what we're doing. They came to my office, believe it or not. And of course, being in Chicago, we have the major people. We have University of Illinois, University of Chicago, Rush,
Mm,
Loyola, Northwestern, Cook County. So we have them, and we're able to use that as a model for everyone else. So we have a pretty good idea of what we're doing. I mean, we've had people, they talk about how many interviews you get. Well, we have a saying, you only need one. I mean, 2 years ago, we had five people that only had one interview, and they all matched.
wow. With
Now, of
that one
course,
interview.
yeah, when I
Mhm.
talked to the director, when I talked to the program director, I was like, you know what? They have five other programs that are interested in them. What do you think you want to do? but but they only had one interview, and they all matched. So
Wow,
our
no, that's amazing.
you
Mhm.
only need one. So
Mhm.
and all of our people do well. We've never not had any person that did not go to the next year. And I said, at least 60%, 70% of our people become chief resident if they want to.
Mhm. Wow. No, I think that's so impactful. And again, I cannot stress enough just really the benefit that students can get from it. So really there is a lot of structure with teaching, with learning board prep material, and even with, the benefit of that contact for the residency programs.
Yes,
And aside from contacting the residency programs, I know that I believe that, letters of recommendation can also be very impactful. And
yes,
so what goes into, well, before going into the letters, how are students assessed in your telerotation programs, and how can that translate over to a letter of recommendation for prospective residencies?
Well, you know what? Since most of the people, when we start the program, can't answer most of my questions when we start for whatever
Mhm.
reasons, the biggest thing is I want to see improvement and I want to see confidence. Because I told them,
Mhm.
they were telling me, Dr. Coleman, I went through the whole program and I don't think I answered most of your questions. I said, did anyone else? And they said, well, no. I said, okay, so that can't be a criteria then. The criteria is you presenting yourself, being more confident, and with the knowledge that you did gain, confidence with that knowledge. That's the biggest thing I look for. I said, then I'm getting you ready for the next step. Then the person at the next step takes you a little bit further. Then the person at the next step takes you a little bit further. That's the way it's
Mhm.
supposed to go. I said, if you all learned it all now, you wouldn't need a residency program. So it's a
Wow.
building. So if I told myself, if I can have you a little bit smarter and a lot more confident by the time you leave my rotation, I said, I think we've gotten you ready for the next level.
Wow, wow. No, that's amazing. And just really, I know, there's a lot of big confidence building, a lot of skill building. Um, Going back to the beginning of the rotation, is there any particular skill that you're looking for? Or also, does it impact students who say maybe they've graduated more than 10 years ago, 5, 10 years ago? Does that have any impact on the start of their rotation as well?
Well, you know what? Depending on what they know and what they do, because
Mhm.
I'll get like I remember particularly I had this one person that they were at Mount Sinai, okay, end up
Mhm.
doing 8 weeks at Mount Sinai. They did 4 weeks of a cardiac ICU, which is all congestive heart failure, okay, and then after that they did another 4 weeks of cardiology, of which they went in ICU all the time, which is congestive heart failure. But then when we went through
Mhm.
our thing with congestive heart failure, because we go from the beginning, from the literature from 1986 to 2024, okay?
Mhm.
And we go through it step by step and go through everything. So now when I look at my person who did 8 weeks of cardiology, I'm like, this should be easy for you. And they'll
Yeah.
tell me we never went through any of this stuff at all. So I'm trying to figure out the
Mhm.
disconnect with rotations because I know what the program directors want them to know. We know what boards want them to know. So how come all
Mhm.
of us are teaching what they need to be successful clinically and on boards? That's the thing. Well, I can't worry about the other programs. I just make sure that we make sure they get what they need before they go to the next level.
Wow. No, and I think that's very good. And I guess another question I have really is just kind of how, again, how can students find value in those experiences in those letter of recommendations? How can students, go about finding an ideal telerotation program?
Well, not just for the telerotation on any program. I would after the second day in the program, I would ask my students, I said, what do you think the purpose of this program is?
Mm.
And they look at me and I don't know. I said, you didn't ask. I said,
Oh.
have you ever did it and asked the program, asked that doctor, why does he have you there? What is his goal for you after 4 weeks or 8 weeks or anything like that? And they said, we never did. So then they would ask me, well, what's the goal of your program? I said, my goal is for you to match. I said, we could talk, we could be academic, we could learn all this other stuff. I said, but I'm doing all this for you to be intern of the year, to be resident of the year, to be chief resident. I'm not doing it
Mhm.
just for a good conversation, you know?
Mhm.
I'm just for you to go to the next level. So the goal of this rotation is for you to match by any means necessary. If we have to repeat, but the biggest thing is you have to participate because you
Mhm.
won't even know how smart you are if you don't answer the questions.
Mhm.
You're so
Wow.
worried about You're so worried about they might know the answer. They won't. Stop giving people credit that they don't deserve.
Mhm.
And if I
Wow.
can get people
Mhm.
to break out of that, I think they'll be okay.
Okay, okay. Wow. No, I think it's really neat just really how you kind of take a very introspective approach. Why am I here? Why is the physician here? And I know you cover a broad amount of material and the student is very well prepared, but at the end of the day, it seems like you still kind of tailor it based on, on a by cases scenario, right?
Yeah,
Do you still kind of tailor the material to the
yeah.
student to best
We
benefit them in your
We
rotation?
do. Yeah, we do because if they're in the office, one, we're going to be a little bit limited. There's some things in the
Mhm,
telerotation, make sure that we do cover in the office. It's hard, but we try to get through those. But we can't get through everything. But then again, there's teaching on each individual patient also.
mhm,
So when we have the patient, if we look at them clinically, then I sit down and talk with them. I say, okay, so tell me what you know about whatever it is the patient has. And then
mhm,
they could tell me to their extent of knowledge, and I'll bring everything else in along with the literature, the data.
mhm,
Because I said, I always ask you guys about the data, and you guys are telling me, well, we don't have any data or anything. I said, well, what about your other professors? They said, well, nobody ever give us data. I said, so your professor is Professor Allah? A Professor Shiva? And they would start laughing and stuff. I said, this is the model. In God we trust, all others have data. So I'm not God, so I need to give you data. When you're talking to the other professors, they should be giving you data. It's not no in my experience, because what of my experience is different than their experience. The experience, what determines everything is the data, the literature.
mhm. Wow, wow. No, I think it's very neat, just really the way, again, you are able to cover the necessary literature, cover the necessary knowledge and information that can not only help but almost ensure a student to match, but still find a way to tailor it to the student, and to the clinical cases. I think that, that's not really an approach that I've really come across very often. Very traditional approaches. I've, seen same individuals follow the same rubric, the same this, the same that, but it really seems like you take a very both personalized approach, but a personalized approach that targets and ensures the student's success. And I cannot, stress just how fantastic of that initiative is.
So thank you. Being as
Hmm.
I was a student a while ago, and I didn't have anyone to do this for me. So when I went
Hmm.
through, there are a lot of things I did. When I went through and everything, I read Harrison's, believe it or not, as a student, I read Harrison's from cover to cover 6 times. Now, did I need to do that? No. So people ask me, they said, well, did it hurt to learn it? I said, no, I still remember all of it to this day. It didn't hurt to do it. I said, but I could tell people things that they don't have to do. And I didn't have anyone to do that for me. So that's why I take a big interest in that. Don't waste time with this. We could do this over here. And it's so funny because when I have the students and everything, and we go through all the data, all the literature, and they say, well, Dr. Coleman, the stuff we just went through on congestive heart failure, how do I look it up? I said, you already got it. I said, you got the date, the article, what it said, the conclusions. I said, what are you going to look up? I said, what you need to do is look up what your other professors didn't give you.
Mm-hmm. Wow, no. And that seems to be a very good approach, very good way, of just really bringing everything together.
Yeah.
And really, I think just another question I have, since you've spoken on the students you've taught and your experience as a student, looking forward now, into the future, how do you see the future of internal medicine? Perhaps 10 years, 5 years from now, both the specialty itself, teaching, and so forth.
Well, internal medicine is definitely going to expand because just like even things with congestive heart failure, with the new medications and stuff we've used for congestive heart failure now, especially at using Entresto, we've essentially made it a subdivision of internal medicine because there will be no procedures to do. There will be no ICDs to put in because we won't have ejection fractions below 30%. There won't be any heart transplants because we won't have ejection fractions down at 20%. There won't be need for antidysrhythmic medications because of what we're using. The medications we're using is so dynamic. We're going to be taking care of those patients. The cardiologists are going to say, okay, you guys take care of this. Let us know if you have a problem, and we're going to go find some procedures we need to do
Mm-hmm.
because those won't need to have procedures anymore.
Mm-hmm. Wow.
So,
And,
so we're
with
going to
the
we're
integration
going to
of,
be
yes, go ahead.
we're going to be encroaching on a lot of different specialties, even with the pulmonary and COPD, even with a lot of different things, which is why the thing that gets me is that if a person is practicing internal medicine the way they should, they're already in those specialties anyway, which is, I always ask them, what do you have to do before you do your 2 year fellowship in cardiology? You had to do what? 3 years of internal medicine. I said, why do you think you had to do that? You had to be a decent internist before they even let you in, you know?
Yeah, no,
So,
definitely, definitely. Wow.
yeah,
So it's definitely going to be it's going to continue covering a broad space of topics,
yeah,
and it's going to continue with the integration of technology, which you say, right?
it will. And the thing I'm really, really concerned about now, especially with the president stuff, is gonna, well, we already had limited rotations with COVID because
Mm-hmm.
even with Rush, University of Illinois, Cook County, and the VA hospital, we're right there, right across, almost across the street from each other. But we don't share students. Like Rush students can't go to University of Illinois. University of Illinois students can't go to Rush. The only people that can go to different institutions are the attendings, and that was because COVID was so devastating. So of course, it's harder to get people to come in from out of town to come in. Now, with things that are going on politically, it's going to make it even more limited for people to be able to get in. So for people that can get in, I'm in my office. I'm there. For people who can't get in, the telerotation is a definitely viable rotation. All the program directors know about hours. I don't know about other telerotations and what they do. They know about hours, and what we did is we put everything together according to the concerns of the program directors. Everything we
Mm,
cover is because they felt the interns weren't adequate enough when they came in.
wow.
I think somebody
And
that will join you or something. They keep
excuse me?
they keep up there that you have people that want to join. I don't know if you see that. I see it. So maybe you're hitting it and bringing them in. But no,
Right.
we try to do things clinically so they can have a good clinical um, rotation, whether it's a telerotation or in the office. We try to do everything academically because the stuff that we're doing is going to be on boards. I heard
Mm,
80%. Somebody told me they took step three. 80% of the stuff that was there was stuff that we talked about. You know, and it filters
mm,
down to step two. Not so much on step one. I don't know how much clinical they do on step one anymore. But and
mm.
I've even had the nurse practitioners tell us that a lot of stuff, our stuff came up on their boards. So.
Wow, really?
So we're trying to do
Wow.
stuff that's net across the board.
Oh, wow. And looking at it from the other perspective, I know there's great preparation, on the students' end. And I'm actually, taking this question from one of the individuals here in the
Mm.
chat. Um, with regards to program directors, I know you mentioned the program director's concerns, the students' knowledge gaps, and so forth. But for successful applicants who are particularly looking to match in either IM or even in a general scope, what would you say are some of the more important things that directors consider in IMG applicants?
Who you did your rotation with?
Mhm,
We all know each other. I mean, we do. So if say I had a person that scored 90 percentile on whatever exams they take and everything, and I had another person that scored 78, because I think you need at least 75% to pass, right? Score
mhm,
78%, 79%. But then the person that scored 90% out had good, solid evaluations, had good, solid rotations and stuff. Okay, their application looks good. But then this other person rotated with the person I knew at University of Chicago, or rotated with the person I knew at University of Pennsylvania, or rotated with the person I knew at somewhere else. And they say, look, this person's a sleeper. I don't know what happened when he took that exam. They said, but that person on that paper is not the person that's rotating with me. They're going to get the slot
mm, mhm. Wow.
because they know what I'm looking for, and we know what each other's looking for. So it makes people talk about the letters of recommendation. It makes a big deal that who's writing that
Mm,
letter has an academic affiliation.
wow. So it's really, connections, connections, connections,
It is. It is.
and
Half
just
the people have no idea of why they match. And then you have things on there that say, well, if you don't have this, you don't have that. Well, if you did this, you did that. Or you had to take boards over and blah, 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 blah. Don't apply. That's
mhm.
BS. There is nothing a phone call can't change. Just for you to know.
No, no,
Trust
and
me.
and I
Trust
think
me.
that's some pretty good knowledge to be aware of
Right.
as well.
Trust me. Trust me.
Hmm.
I know. we've had people that had slots, and some of our people bumped them off. Hopefully, they got somewhere else or something like that, but they were bumped. I mean, you would be amazed at the conversations that go back and forth between programs themselves and between me and programs.
Wow. And so that just really further emphasizes the importance of telerotation, who you're doing your telerotation with, again, because some of the international medical graduates, they might not have the accessibility to attend rotations in person. Again, not only do they have the benefit of attending the rotation online, but when you attend it with the right person, that's
Right.
really the winning combination.
There you go. That's
Wow.
the And even the same thing, even if it's in office, it's the same thing. Even more so with the total rotations. I think people feel where, well, if they do a total rotation, that there's something lacking. No, guys, the whole reason it's set up like this is the program director is saying that you're doing all these clinical rotations and still don't know shit. I'm sorry to use that term. That's the problem. They're saying they're doing these rotations, but what's going on? The deductive thinking isn't there. So,
Mhm.
yeah,
Wow. Mhm.
trying to
And
make a good effort. We're trying to do a good effort to mix the two when we do our clinical rotations. But then, if we're busy, it's hard. I can see how programs didn't do that. It's hard, but we get the major thing that the directors need, for the student, even on our clinical rotations.
wow. And when it comes to the end of the clinical rotation, students have their LORs, they have their steps done and ready. Do you have any suggestions on how one can go about crafting their rank order list? What kind of goes
Well,
into the ranks? If there's any insight that you can share on that as well, please.
well, if you're a quiet person, like I tell people to come to the office, oh, Dr. Kum, I'm just so shy, and sometimes I can't participate. Then I tell them the first day, then you know what? You do not want to apply to Rush University. You do not want to apply to University of Illinois. You do not want to apply to any of the academic centers because you have to participate. I said, so right there, you're eliminating yourself because then, I mean, even if they interviewed you, they'll be like, okay, what was there? They didn't talk to me. They didn't do anything. The biggest thing they could do before that, other than going through and doing well, everybody doesn't always do extremely well, but doesn't mean that you can't match. So the next best thing is making sure that your that personal statement is just as good as your grades you know if you put a good personal statement together, and not the thing that I went into medicine because my uncle was a doctor or because I got a relative that was sick or something like that. That may be the case, okay, but you have to make it stand out from everybody else because we hear that so much. We want you to be honest on what put there, what did that. Or if a person they were at home, they were there and they were practicing, they were fine, but then they had to leave for whatever reason. It could have been a military war, could have been their spouse had to come to another country, anything. That's a big deal because we're looking at, okay, they're willing to sacrifice. That's the person we want in our program. They're willing to sacrifice. They could work with the other interns. We could do something with them. So people sometimes think when they had to do something, they had to leave a program, they had to leave home, they came over here because their spouse was working. They think that's a bad thing. No, that's a big deal. You sacrifice a lot to do that, and we want that person in our program.
Wow. Hmm.
That personal statement tells a lot. The personal statement is the only thing when I'm looking at everything, even when I get it from my other friends, okay, from the other professors, okay, I got what they said about you. I got what board said about you. I got your scores and everything. The only thing that you're telling me about you is that personal statement.
Hmm. What do you say about you, right?
There you go. There you
Wow.
go.
I think
That,
that's a very good combination.
yeah, and I think a
And
lot of people don't
mhm,
don't
yes, go ahead.
realize. As I don't think a lot of people realize how important that personal statement is.
Wow. No, so there's really a lot of impactful qualities that can go into a successful residency match then. So,
Yes.
because we've been covering the connection aspect, the value aspect of the rotation, the personal statement aspect. Academically, would you say maybe that personal statement in connection with the experiences, both from the telerotations and otherwise, do you think maybe that can compensate for, say, maybe a low step score or a low academic performance?
Oh, absolutely. Absolutely.
Mm,
That's why I tell people, and they
mm,
say, well, when I was thinking about not applying to this program because they said if you had this, don't apply. And I would smile and I say, you'll be surprised. I said, I
mhm.
said, what they said. I said, but you'll be surprised what happens during phone calls and stuff like that. Like I said, most of the people match, and then I have the seniors telling the other people I matched because of blah blah blah. They have no idea about how they matched or why they matched in the whole
Mhm.
scheme. They don't know who was talking to whom and who did what,
Mhm.
and then they match in this program, but they could have been in this program over here, you know. At the end of the day, they end up matching, but 90% of the time, they won't know why.
Oh, wow.
Yeah.
And I'm taking some questions here from the chat. We are focusing on one rotation, particularly your rotation, but from a more broader perspective, would you recommend or say there is a recommendation to take a certain amount of rotation electives, perhaps, two university or three outpatient rotations? Or
Yeah.
again, is it more just dependent on the value and
You know,
just the effort that the student puts?
well, of course, it's always dependent on the value. You want to do, believe it or not, you want to do a little bit more outpatient because our whole system is changing to that anyway. We
Mm,
realize that our system is never going to be, inexpensive as long as we have a hospital-based residency program system. We can't have 20 people, residents rotating on 20 people in the hospital and expect the system to decrease, on what our patients pay. We have to do a better job in outpatient management. We've been kind of doing that for the last 5 years. It's just going so slow because all the people that are teaching people to do outpatient medicine were always doing inpatient medicine. So this is a whole new thing for us in general.
mhm. Wow. Yeah. No. So essentially, there's no really any checklist or again magic combination. If you can get the same value from one virtual rotation as you would in either two outpatient, at the end of the day, outpatient is a good way to go. But in the instance that you can't, telerotations are good alternatives. But at the end of the day, there's no, I need to do A, B, C, and D, right?
Right. Right, because there is
Mhm,
no, I mean, of course, if you could do, now, I mean, the ideal is if you could do an outpatient clinical rotation and get the academics to come with it, that would be the
mhm,
ideal. But, that is just, even for me, that's hard to
mm,
do. And
mm,
sometimes I've had some of my patients, my students in the office, I let them sit in on one of our academic sessions, and they were like, well, Dr. Coleman, how come we didn't do that today in the office? I said, because you saw 15 patients. I said, I said, I said, you chose to see the patients. So we saw the
mhm,
15 patients and whatever scraps, we could put together. Because, there's a basic amount that I told the program directors that we're going to go through regardless of what rotation they did. So,
mhm,
the core of what we do, we still try to do regardless whether they're in the office or in the telerotation. But yeah, but the telerotation is, that's the cream of the pie for academics. I mean, we have the
mhm,
telerotation, we have an advanced telerotation, believe it or not, because of that.
mhm. Wow. And going back to LORs again, I'm seeing questions here from the chat. I'm seeing an individual asking if a recommendation or an email from an attending, would that make a difference? Does that hold different value as making, a phone call or, attending versus, you know,
Well,
do emails and calls hold a difference between the
yeah.
impact of a student's success, would you say?
Oh, yeah. I mean, of course. If a person can make a phone call, that's always better.
Mm,
Most of the time
mhm,
when I'm making a phone call, it would have been for people I did write a letter for, you know.
mm,
And so it's
mhm,
easy to call the program director and say, hey. I sent you a letter regarding so and so and so and so and so and so. Did you get a chance? I mean, perfect example. They would be like, well, we have, these patients, these students, and blah, 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 blah. And we really didn't get a chance to look at that. And someone would even tell me, I think we've just about formed our list, and, we got our 20 people, and I think we're pretty much set. And I said, this is even better. I said, this is better because now you filtered out your
Mhm.
20 people. You don't have to worry about everybody else. I said, now, I want you to look at your 20 people that you're going to take and look at my person. Now, if after you do that and you look at my person with your 20 people and you still take your 20 people, I'll shut the hell up. But most of the time, we end up bumping somebody that would have had
Mhm.
that would have been in the program. So it makes a difference. Only, and probably people that got bumped didn't have anybody calling for 'em. I mean, but what can you do?
Mhm. No, definitely.
Yeah.
And are there any impactful experiences from your students that you recall? Was there a student in particular or their journey in particular that you remember from those that you've mentioned, from those who you
Well,
mentored? Excuse me.
I have quite a few now. They're texting me because they're going to be chief resident next year. So we have a long tradition of that. But the reason I started calling, we go back a little while ago. At that time, I had 3 students. At that time, they were my best students ever up to that point, and they didn't
Mhm.
match. And I was like, okay. I mean, first of all, I'm trying to figure out how do you not match, and then I'm sitting there. I'm like, so then I was saying, well, Dr. Coleman, what do we do? And I'm like, I was stunned. I'm like, I had no idea of what to do. So they happened to be in Chicago. They stayed with me. They did some other stuff. They did everything. Made sure that we shored up their clinical stuff. Went through everything with their personal statements. Did some interviewing stuff with them. I mean, their interviewing should have been okay. It ended up that all of those people matched the next year. All three of them matched the next year. All of them were intern of the year. All of them eventually became chief resident. Okay. So then by now, and they've had the same program director for 3 years. So when they were chief resident, I said, well, do me a favor. They said, what? Just ask them. And you could tell them, I asked you to ask them. Okay. You applied the first year, they didn't take you. And the next year, they took you. And apparently, you're doing well in the program. Just say, Dr. Coleman wants to know what was there the year before that kept you from taking me. Each one of them went to their program director. The program director did do due diligence and pull their records. And they told them, I don't know. They said, I have no reason why we didn't take you the year before.
Oh, wow.
That was really amazing. So I felt
Wow.
better. I felt better. I didn't feel that I let them down or anything. They said no. The program direct, each one of them told them after going back and looking at your stuff, and especially seeing you where you are now, they said there is nothing distinguishing between those 2 years that stands out on why we didn't take you.
Mhm.
So,
Oh my
but but
goodness.
but what happened the second year is I called all the program directors too. So
Mm.
that's when that's when I started calling program directors because you know what, they had everything, they good scores, good rotations. There was no reason I could have figured that they didn't match, and
Mhm.
apparently program directors look back on it, they hadn't they could not tell them, well, this year it was this and last year was this. They couldn't tell the difference between the two applications.
Wow.
Yeah,
Wow. Oh my
but
goodness.
I did call
Mhm.
the second. So
That's the only difference.
right, that was the only.
Just a tiny little but very impactful detail.
Exactly.
Oh, wow. No, well, that's so amazing. And thank you so much once again for sharing your stories, Dr. Coleman. And for students who are watching this meeting, those who are either, in their rotations or they're in their match cycle now, do you have, any closing remarks for the students? Any final pieces of advice you would like to share to them?
Ah, yeah. One, make sure you get a good rotation, whether it's a telerotation or you're in person. Try to make sure that the person, because I know sometimes it's hard to get rotations, but you want to try to make sure that the person has an academic affiliation. It makes a
Good
big
to
difference to us. When I'm looking, and like I said, when I'm looking, and this is my friend that's over there at University of Pennsylvania writing, I can trust what he's telling me about that person. regardless of anything else. And of course, they would be writing to me and calling me because they know that person could be of interest to me. And they're letting me know, look, we would take them in our program. Do you want them in yours? So it makes a big difference on who writes the letter. And then, of course, it makes for the person that's writing the letter, if they're academically inclined, then they'll want to teach. And, you're not just there doing their paperwork for them,
Mhm. Wow,
which I
no,
hear
thank you so much.
what they're doing. They're writing notes, they're doing all this other stuff, but they're not getting any academics.
Oh, wow. No,
So
thank
just
you so much once
uh,
again. Yes, go on. Hmm.
up for the rotation isn't enough. Just let
Hmm.
them know, okay?
Yeah, no, definitely. And thank you so much, Dr. Coleman. Thank you so much once again. I'm going through the questions here in the chat, and it seems we have, really covered all of a good majority, if not all of the questions that were asked here. And just thank you once again for imparting that invaluable information, just really on the importance in choosing your rotation, finding value in the rotation, ensuring that it possibly has or that it has an academic affiliation. The connection really has great value and can impact just as well as your personal statement can when it comes to success in your residency application. Just really, I really want to appreciate the way you synthesized all of this for us, because there's just so many factors that go into matching into residency, but likewise there are just as many ways individuals with confidence, can make themselves stand out and become the ideal resident candidate that gains that acceptance. So for that, I
Absolutely.
thank you once again, Dr. Coleman.
Okay, thank you.
Thank you so much. And for everybody who is still in the chat with us, thank you so much for joining this chat. If you're interested in joining a virtual program with Dr. Coleman, you can contact IMG Helping Hands, our coordinators. We will be happy to discuss, information further. I will be providing information below in the chat. Dr. Coleman, if there's anything that you would like to provide in the chat as well, again, additional information. But again, just really thank you so much for everything you've shared to us today.
No problem. You and Miss Banks do all this part over here. Okay. All right then. After
That's
the administrative stuff to the people that know how to do it well, now I'll stick with the teaching part over there. Okay, but you have my number and everything. If you have any other questions yourself, you want to get in touch with me, you know how to get in touch with me. Your group knows how to get in touch with me or Miss Banks. Okay.
definitely. Thank you so much,
Okay.
Dr.
All right
Coleman.
then.
And I
Take
hope you
care.
continue having a great day.
Okay. Thank you. You also.
Thank you.
Mhm.
Thank you so much. And thank you so much to everybody who has joined this video call with us. This is again building a strong ARIS application, navigating through the residency cycle and the match. Thank you so much, everybody, once again, and we hope to see you in the next webinar.